Hello, everybody. This is Andrew Gums. This is our 57th episode of our podcast, Artificial Intelligence and Cybersurgery. We're the official podcast for our journal, Artificial Intelligence Surgery, the only journal, or I should say the first journal dedicated to surgery and artificial intelligence. I'm here with my co-host, Vincent, I should say Professor Vincent Grasso, and he'll introduce our next guest.
Thanks so much. Yeah, this is exciting. Episode 57. That's not we've come a long way. It's a great pleasure to have Professor Iyer on today. He's in Singapore. He's a surgeon and hepatobiliary surgeon and transplant physician. He's involved in a lot of interesting things happening in Singapore. I think he mentioned right now that he's traveling. He's off site. But it's a pleasure to have you on, Professor, today on Sunday to our podcast. And if you could tell our audience a little something about you, and we'll get into our discussion. Thanks for joining.
Thank you very much, both to Professor Andrew and Professor Vincent. I'm Shridhar Iyer. I'm a HPV and liver transplant surgeon at the National University of Singapore. I moved to Singapore about 24 years ago now. So I was in India previously, trained there. My interest was HPV surgery. I did training in surgical oncology in India, moved to Singapore, and got into HPV surgery and transplantation, which happens to be my interest.
Where in India were you born, and where did you do your training? I've been to India,
Yeah.
my goodness, about 7 or 8 times now. So it's a massive place, but I'd be curious to know.
Yeah, so I was born in a state of Maharashtra, Nasik. I did my training in Mumbai. Previously it was called Bombay. And I was in at Grant Medical College and then subsequently Tata Memorial Hospital. It's a surgical oncology institute just dedicated to cancer care. So that was exciting, but I've been to different parts of the world. So in addition, I lived in Taiwan for a year to train in liver transplantation. And they were at the cutting edge then for living donor liver transplant, interestingly. So which has taken off in a big way all over Asia.
All over the place, yeah, for sure.
Yeah.
And what brought you to Singapore?
I wanted to get to a place where there was transplant options, because when I left India, it was in 2000, transplant had just started. There was no big program then. Now it's a different scenario. But at that time, there was little opportunity. So I was contemplating UK and US, but Singapore geographically is close to India. So it is easier for me to travel if I need to go back and forth. So that was the impetus, and it sits right at the geographically at a very good location and with accessibility to different parts of Asia, and of course close to India. That's why I decided to make it my home.
And it's absolutely beautiful. I've only been there once, but it's absolutely spotless, immaculate, beautiful. The climate is, you can't beat it. Is there a problem with I'm trying to think of the right word. Is it monsoons there?
No, there's only one season there. It's either summer or monsoons every day. So
wow. Okay.
So we sit on the equator.
How long is monsoon season?
No, every day it either rains or it's absolutely sunny. So the weather can move quite fast. So we don't have seasons or changes in the climate as much. So we have almost the same constant weather throughout the year.
But you don't have serious monsoons. You don't have, we call them
once in a while.
Yeah,
once in a while, but it's unpredictable. Yeah.
But it seems like in the Gulf Coast, my father's from Anguilla, British West Indies, and we have a dedicated hurricane season. Because of the geography, it's every year they're hurricanes, but it doesn't sound like that's the case.
No hurricanes. We just get massive rains sometimes.
Yeah, okay.
That there's some flooding which goes off very quickly. So it's a very great place to live, and you don't have that many weather changes. Of course, if you miss winters, then that's a sore point for some people. But otherwise, it's a constant climate, stable politically, economically, great, and at the forefront of development in many arenas. So it's a great place to make home, and a multicultural society.
Absolutely.
That makes it very good. A lot of expat population as well.
So we did a webinar about 3 or 4 months ago. Tell us a little bit about your webinar and what who you do it with, and how long you've been doing, and what you're trying to accomplish. Like, who's your audience?
Yeah. So basically, I was fortunate to have you on the webinar actually, and we were
fortunate to be on it.
So I sit in different societies. As a HPB and transplant surgeon, I am a part of Hepatobiliary Association, the International Liver Transplant Society. But I also am a part of ELSA, Endoscopic and Laparoscopic Surgeons of Asia. ELSA does a webinar on various themes. And of course, it's a group of endoscopic and laparoscopic surgeons. So it's not restricted to HPB surgery, upper GI, colorectal, hernia, the works. But as a part of the ELSA Society's endeavor to sort of push the boundaries, apart from the annual meetings, and we thought it's apt to have a webinar on AI in surgery. And that's how, there was no second thoughts. We said we should get you. And it was an interesting conversation, and opened up our minds to a lot of extent. And our audiences, again, all the ELSA membership, it's a huge membership, over 5,000 people across Asia. But again, so every webinar, we have at least about 100 to 150 attending, but we also post it on YouTube and the ELSA channel as well. So that makes it, we get a wider reach with that. And it was extremely well received, and people enjoyed it. And we hope to do more of this. But again, my interest in this area is basically to see where I can use or where I can use this for better patient care in my area of work, which is HPB surgery. But again, AI in surgery, after discussion with you, has a huge potential. Training and education, patient care, of course, learning from large data models, etc. So
you bring up a good point, and actually we're coming up. We're going to have a consensus conference on new definitions, and so as artificial intelligence is entering the realm of surgery, what surgery is and what it is not, is up to debate. And I'm very interested, and you mentioned ELSA. I trained in the United States, and back when I was a resident at Yale, I learned endoscopy. We had to do, at least I think around 80 endoscopies just to graduate. I also did percutaneous techniques, with the vascular surgeons. We were doing, endovascular procedures. And, essentially, later on in life, I worked in Paris, and I worked in a department that was it had one chief, but it was composed of digestive surgeons, but also of gastroenterologists. And we were working together in one team. And there are even places in Paris, HPB centers, where they have surgeons who do endoscopy, ERCPs. They have surgeons who do embolizations, of the portal vein and everything. So this, to me, is really the future of surgery, especially as we get more and more AI, we get more and more autonomous actions, we get more and more support from computers and more autonomous robots. It really seems like things are fusing. Those three traditional different disciplines are really fusing more and more. Now, in France, it's very difficult for a surgeon to touch an endoscope. You have to get a diploma. So I actually applied, and I'm gonna be doing a diploma at IRCAD in Strasbourg this year, because it bothers me that I'm not legally allowed to do something I know how to do. So I'm going to do it. So I'm all of that to get to my question. In Asia, I'm sure it's different from country to country.
Yeah.
Can you give me an idea, because you've been in India, you know Singapore, I know you're currently traveling. Do surgeons in Asia have access to endoscopy? Are they allowed to do endoscopy? Are they allowed to do percutaneous techniques? And if you give us a little insight into Asia, how it works.
Yeah, so it's great. I mean, for a very relevant question, I mean, the upper GI surgeons typically will do, I mean, all surgeons do endoscopies, upper GI, lower GI, routine colonoscopies, routine upper GI endoscopies. The surgeons who are trained in upper GI surgery will, if they have interest in it, then they do advanced endoscopic work, which includes endoscopic mucosal resections, percutaneous endoscopic myotomies. So it sits at the cusp between gastroenterology and upper GI, insertion of PEG tubes, etc. The colorectal surgeon, again, there is one colorectal surgeon who has interest in advanced endoscopy in our institute.
Yeah.
And he's done over 1,000 endoscopic mucosal resections, endoscopic resections. So if some surgeon is interested, then they can do endoscopy, but all surgeons are trained to do upper GI and lower GI endoscopy. And it's up to the surgeon whether they maintain the skill sets. But when it comes to any research projects which involve endoscopies, for example, AI and endoscopy, diagnostics, most surgeons would participate. I mean, in creating that data sets and things like that. As far as HPB is concerned, ERCPs is largely done by gastroenterologists. But having said that, we have now some surgeons with interest in ERCP. So advanced endoscopic techniques for biliary interventions. Again, we recently recruited a surgeon from Belgium who's trained in HPB surgery and liver transplant, but now recruited only to do endoscopy under the gastroenterology department. Nice. So it is a very interesting mix. So we do, there's no, although the gastroenterologists do seem to have a turf with regards to ERCPs, rest of endoscopies is sort of mixed. Percutaneous techniques, that's interesting area. The radiologists generally will do it, and none of the surgeons do PTCs or biopsies, targeted liver biopsies. They won't do ablations. But having said that, when we do laparoscopic ablations, again, that's under the realm of HPB surgery. But percutaneous ablations are all done by radiologists. So that is extremely well demarcated. So again, it varies in different parts of Asia, but in Singapore, that's how we function.
There are more and more, well, we're actually developing one, but there's also a company, I think they're called Quantum Surgical, that where they essentially have an arm that does
Mm.
a robotic arm that does autonomous navigation. So, the surgeon or radiologist has to push the needle in, but everything is lined up with this arm.
Yeah.
So I think, more and more, as we get more and more autonomous navigation, it would be a bit of a shame for surgeons to not, use something like Quantum Surgical's arm
Yes.
to do ablations. Maybe even during a procedure, you could do a colonoscopy and you could even treat a liver met at the same time. Just as it seems to me a shame that
Yeah.
surgeons aren't realizing what's on the horizon and what's
Yes.
realizing, the long-term effects of not paying attention to technology, as you know, is something I'm very worried about for future surgeons.
Yeah.
Vincent, what do you,
So,
oh, I'm sorry, go ahead.
yeah. So that's a very interesting point. I mean, we the Holo Medicine Association was formed. One of the Holo Medicine Association use 3D reconstructed images for liver, and with that we can actually overlay onto patients' abdomen. We have used that technology to in intraoperative navigation in, for example, disappearing colorectal metastasis after chemotherapy. And sometimes you don't know where it is. You use a combination of ICG for the superficial lesions, then you overlay the preoperative image where the lesions were better seen. Again, the liver is deformable. Once you put the laparoscope in and start mobilizing, it is deformable. So the university now, some of my colleagues are developing deformity models. So they study the characteristics of the liver and create a deformity model so that we can overlay the image and make, as long as the fiduciary points are matched, where the hepatic veins are, where the key points are, you move the liver stretch, the image will adjust itself. So you can do targeted, again, this is what surgeons are doing, but this needs to be brought back to the radiology as well. So there is interest. I'm sure it will move. But at the moment, again, percutaneous ablations are still held by the radiologists, but that's an exciting area. We are working with the radiologists closely, and I'm sure we can pique their interest as well.
Great. So,
Yeah.
Vincent, what are you thinking? I know you're working on some things behind the scenes with me on this topic. What are your thoughts about the fusion of percutaneous endoluminal, I should say, and surgical techniques? So how do you see the future panning out?
No, I like what I'm hearing. It's so exciting to hear that there's, let's just say, a willingness and collaboration between the radiologists, the GI doctors, and the surgeons and your ecosystem. That's not the case everywhere else. There's still a lot of territorial disputes, and the problem with these silos is that the data that the radiologists have, the GI doctors have, the surgeons have remains segregated. It's difficult to integrate and analyze. Just think how exciting, Andrew. There's a surgeon there that's done 1,000 mucosal resections via endoscopy. The good news is that in that physician's mind, there's a lot of experience, right, to do the next one. The challenge is that those 1,000 procedures reside within 1,000 files related to capturing the endoscopy. So there's 1,000 files. And if you do computer vision on those files and other things, you create a very interesting knowledge base, right, for autonomous action doing mucosal resection. So that's where we all need to move. We need to be able to move to harmonizing and integration these data sets so that the machine actually benefits from this fantastic experience. Otherwise, that information resides in those files on a hard drive and it doesn't get accessed, right? So it's kind of like lost in transit, so to speak. But what's so exciting is that there's a willingness there for people to work together, and that's great for patient care. And I think that will increase patient care quality and decrease cost, unnecessary repetitive procedures being done by all these different professionals, right? We know that you just keep doing endoscopies and colonoscopies and people get passed around. So this is for we in the AI space, this is music to our ears, Shridhar. So this is great to hear from your team.
So in addition, I think it's these repetitive actions by experts
Yeah.
can be tracked.
Yes.
And somewhat, I mean, again, one of our team, that surgeon was interested in how we can capture the expert surgeon's movements and fast track a trainee into those movements with guidance. These movements are tracked, and then these are translated into actions onto the laparoscopic procedures. And those actions are, you show where the instrument needs to track, you show what actions need to be done. So that's one more area which is being developed, and we are excited with that as well. So hopefully it can shorten the learning curve for the surgeons. And I mean, in the past, we only had open surgery. Now we have laparoscopic surgery, we have robotic surgery, and we have more trainees, work hour restrictions. So what the trainees need to learn is much more now than what it was 20 years ago.
Oh, yeah.
And they have to learn in a shorter time. So what can we do to make it better for them?
Let me ask you a question. I have a question because when I was in training, it was always a 3 o'clock in the morning problem where in the ER there's a patient with cirrhosis and varices that's bleeding, and then it's bizarre medieval procedures to try to stem the bleeding, which is it's too late, obviously. So you guys are much more close to this. How do you see, this whole AI ecosystem helping decrease the worsening of our cirrhotic patients to that point where now they're bleeding varices and it's a mess and those poor people suffer? How do we hedge that collectively? Do you see is that a problem in your domain?
Yes, definitely a problem. But again, there are a few platforms that are being developed to aid decision making. And these platforms, I mean, they have very interesting names in our institute. So one is called Endeavor AI. It basically takes data from the electronic medical records, all the telehealth engines, and then it gives a clinical workflow automation. Okay. It has also built-in AI length of stay predictor and disease progression predictor for chronic disease. But for these acute situations, there is a availability now of a decision-making tool to help the staff on the ground. And I was involved in a decision-making tool for acute pancreatitis. So this is being developed for different conditions. But for acute pancreatitis, we did a review in our own, and I this will be common to many other places, where we looked at what is the compliance to the guidelines when a patient comes with acute pancreatitis, for example. So we found that the compliance to, let's say, any international guidelines, AAP, or IAP, APA guidelines, the Japanese guidelines, the compliance to each one of those statements varies from about 20% to 80%. But so a decision-making tool was developed for the surgeons on the ground or the doctors who are the first port of call, to have a decision-making tool to make sure that all these guidelines are adhered to. So similarly, in a patient who comes with a upper GI bleed, can avail a decision-making tool to help you with that. In addition, just like ChatGPT, we have developed something called Russell GPT in-house. And that basically, I don't know why it is called Russell GPT.
I was wondering. I was like, well, what could that
Yeah.
possibly be? Yeah. Must be the
Yeah.
name of one of
So
the programmers.
unfortunately, at this point, I don't have an answer to it. But basically, what it does is it's again based on large language model, and it analyzes whatever inputs are there and helps create. I mean, a lot of doctors spend a lot of time, especially on the floor, trying to summarize the data of a 30-day admission, for example, into a discharge summary. So it automates the discharge summary process. It
Sure.
automates, there is ability to automate the process
Yes.
to write referral letters, which are meaningful. Otherwise, I see a patient in the clinic who was admitted last month for 1 month and referred to HPP. I'm searching for what is the referral for. And so there is automated referral letters, automated GP replies, and that eases the workflow for the doctors. Now, of course, these decision-making tools also, of course, apart from this is what the junior doctors love it because it saves time for them. It just was launched this July, and so it's still under adoption. But there are some other functionalities being built in. Now, you don't want a patient walk into the clinic knowing more than the doctor. And with ChatGPT at fingertips, there's a real possibility of that happening. So information at fingertips, again, the ChatGPT is not focused towards healthcare. So the Russell GPT actually is targeted towards doctors' questions, for example. So I didn't have a comparison with ChatGPT, how it does, but we should have the data probably by next year.
Well,
Nice.
I hope you publish in our journal. That sounds like an interesting study. And that reminds me, because we're already at the 30-minute mark. You have developed a survey analyzing, some questions about artificial intelligence in transplant surgery. We've sent it to a few societies in Europe. I was wondering if I could send it to you, if you could maybe send it to some of your societies.
Yes.
Okay, great.
Yeah. So I'm a part of this, an active part of, I'm one of the council members in the Asian Society of Transplantation.
Okay.
So which is again a huge membership, so I can send it across to the
That'd be great. By all means, if you think of any questions you want to add based on Russell GPT, I'm wondering. Actually, it's already been sent out to Europe, so we better not change it this time around. But I'm very interested to see how Russell GPT works. We will see.
Okay, for now it is submitting patient data effectively. So of course you need to read through it, make sure there's no minor errors here and there, but it's doing a great job.
No, that's fantastic. Trust me, I'm now in France, and I have to do my discharge summaries in French. So any help I could get would be greatly appreciated. So I'm eagerly looking at the outcome of GPT, trust me. So
so one interesting thing it does is because we are multilingual society, let's say a doctor speaks to the patient in Chinese, it translates to English at the same time. So I just have to read through and make sure it's correct.
No, of course. That's you have Chinese. Oh, you must have so many languages. I'm not even going to attempt to list them. In Singapore, how many official languages do you have?
4. English, Chinese, Malay, and Tamil.
Wow, interesting.
Incredible.
Did a lot of the Tamils leave Sri Lanka and go to Singapore? Is that why?
Sri Lanka as well as southern India. This was pre-independence.
Okay.
So, I mean, pre-Singapore independence. So it's probably in the early 1900s.
Oh, I see. Interesting.
So there's population.
Nice. So Vincent, I'm going to let you close us out here. We only have a few minutes left.
Well,
Get your perspective
fantastic.
on how AI can help transplant. But before I let you speak, Vincent, I wanted to ask you earlier, have you seen these robotic liver transplant implants? And do you have any thoughts on that? Where they put the liver transplant in the patient using the robot?
Yeah. And there's no autonomous action there. It's all human action.
100%.
So I feel scared about that because there are some people who do it, large volume centers.
Yeah.
But if a clamp slips, or if the warm ischemia is longer than usual, I'm just worried about that.
Sure.
But I don't know where things will go, and the pace at which things are moving, it will be more common than we think. So we need to be prepared for that. But at the moment, it looks like a sledgehammer for for a small nail. So yeah.
No, I understand. All right, Vincent, after you.
Well, it's very exciting. I'm looking forward to the GUMS GPS platform that I guess we're going to build and follow up for the Russell one.
Yeah,
Professor,
Yeah.
it's going to be exciting. Professor, thank you so much for being on our 57th podcast. You're doing great work in Singapore, and we're looking forward to following up with you on some things. So closing it off for Andrew and Vincent on our AI Surgery podcast, and looking forward to the 59th coming up, I guess, pretty soon. And the 60th.
Wait, 58th next, right?
Yeah, for the 8th.
But we're coming up
get
to
to 60 pretty soon.
And I figured out who that's going to be. I'll tell you later.
Oh,
Vincent.
great. Okay.
All right. Have a great rest of your evening.
See you. Take care.